All right, we ready?
Yes.
Yes.
Okay, good afternoon, everyone. I don't think I know a lot of you guys, at least the ones that I see. But at some point you might work with me on the hematologic malignancy floor. So today we're going to talk about lymphoma, which is a pretty huge topic. It's not one disease. I will try to cover the basics. Um, this time I'm going to start with a couple of cases just to get a sense of um, how much you guys know, get you a little bit more involved into the presentation, and then I'll take it from there. Let me see. It's not working. All right, so let's start with this first case. 30-year-old guy presents with left neck lump growing for 4 or 5 months. He reports night sweats, weight loss of about 10 pounds within the same period of time. He has very intense pruritus throughout his body that keeps him up at night. And in the exam, you palpate left supraclavicular lymphadenopathy, a little bit indurated, non-tender. In addition, a left axillary mobile non-tender lymph node. And you notice that his skin has excoriations in all four extremities. So given this presentation, I guess the topic gives it away, but what do you suspect, and how do you move on as the next step of the workup? Someone.
Lymphoma.
Yeah, lymphoma in general. If I had to ask you, what type of lymphoma?
Hodgkin's.
Why?
The itchiness tipped me off. But
Yeah. Okay. Good. I'm not going to tell you the answer, but I like your answer. What do you do next?
Biopsy.
Get a CBC.
All right, biopsy. You can do that straight up, palpable lymphadenopathy, or try to get some imaging to see how those lymph nodes do. Likely whoever service you're going to call for a biopsy, they're going to request some imaging too to see the anatomy. But that's true. Eventually, we want the biopsy. Yeah, CBC, of course. The chances are that you're gonna have that, but you definitely want a biopsy, right? And you're gonna have all these labs um, available to you. All right. So, do you call for let's say that which service are you gonna call?
Wait for the results and then call. Like, we have to wait for the results first.
Results of what? The imaging?
Imaging and, I don't know, biopsy. But most likely,
All right. So you decide to get some imaging. It shows pretty much that you have supraclavicular lymphadenopathy and axillary lymphadenopathy. The biggest lymph node mass is in the supraclavicular area. Who do you call?
surgery or surgery.
Oncology.
They don't do that. I think, yeah, surgery.
I guess my question is, what type of sample are you okay getting?
I think either like an excisional or a core needle biopsy, because I think fine needle is not enough of the sample.
Yeah, good, because that's very frequently the case. You guys call the ENT, let's say, for cervical supraclavicular lymphadenopathy, and they tell you, oh, we're going to start with an FNA, and that, in the 99% of the cases ends up delaying the whole diagnosis by a week or so, and that sometimes can be a crucial period of time that within which the patient can deteriorate. All right, good. That's it for now for this case. We can talk about how do you, once you get a diagnosis, how do you stage someone, and what do you do before you're ready to stage? Okay, second case. 57-year-old guy with hypertension, diabetes, presents with fatigue, abdominal pain, weight loss. You find him with an epigastric mass. You palpate deep in his belly, masses in the right lower and left lower quadrant. And he has right lower extremity edema and scrotal and penile edema. You get a CT that shows massive abdominal pelvic lymphadenopathy, with the biggest mass being in the retroperitoneum invading the pancreas, and splenic lesions. His labs show a mild anemia, LDH is slightly elevated, amylase lipase are elevated. Whatever I'm not listing are considered normal. What's your suspicion here? Lymphoma. Yeah, true. But starting to think about lymphoma, if you had to choose between slowly growing lymphoma versus an aggressive lymphoma, what would be your guess here?
Probably
Aggressive.
aggressive.
Aggressive, yeah.
Mhm.
Okay. Case 3, 64-year-old guy with hypertension, diabetes. He's referred to your clinic for leukocytosis. He feels well, has no complaints. Exam is pretty unremarkable for lymphadenopathy or hepatosplenomegaly. And these are the results of his CBC. He has a mild leukocytosis. It's lymphocytic. He has no anemia. He has no thrombocytopenia. Unremarkable chemistries and normal LDH. What's your suspicion here?
Let's see that.
Yeah.
Leukemia?
Say it again.
Leukemia?
Right. What type of leukemia? It's definitely something in leukemic phase, right? He has lymphocytic leukocytosis.
CLL.
Yeah, you're talking about a chronic leukemic process here. And, you know, any lymphoproliferative disease can present with lymphocytosis, but what, you know, even an aggressive lymphoma can present with leukemic phase and circulating abnormal lymphocytes. What makes you think that this is more of a chronic process here?
Incidentally found that it's not such a high white count.
The white count itself doesn't quite matter, but the whole presentation, as you say, right? He's asymptomatic. He doesn't look sick. The rest of his cell lines look pretty good. If that was an leukemic phase of a lymphoma, for example, usually that's advanced disease. You would expect to have high LDH. You would expect to see some cytopenias as well. The patient would likely look and feel pretty sick. So yeah, that's pretty typical presentation for CLL, which is the most usual leukemic phase for indolent lymphoproliferative disorder. And he has a particular staging system. He will be, for example, stage 0 CLL. All right, 54-year-old guy presents with epigastric and left upper quadrant pain, reports fatigue, night sweats, significant weight loss within 1.5 months. He has temporal wasting in exam, palpate his spleen, and his labs are 37, almost 38,000. Again, lymphocytic predominance. He's a little bit anemic. He's thrombocytopenic, mild AKI, some transaminitis, direct bilirubinemia, LDH in almost 1,200, uric acid 3.3. What's your suspicion here?
Acute leukemia.
Acute leukemia could be the case of this guy. Since we're talking about lymphoma, I'm giving you the definitely that could be an acute leukemia that you would move on by checking the peripheral blood smear to see if you have these abnormal looking blast-like cells. versus more mature looking cells. Here I'm telling you that the peripheral smear shows mature looking lymphocytes. What do you suspect? Do you suspect indolent lymphoma, aggressive lymphoma?
Aggressive. Aggressive.
Okay, that's an unusual case, and that's why I chose it, just to see that sometimes indolent lymphoma can actually present pretty aggressively. All right, so with this case in mind, let's move on to our talk. So the way you should start thinking about lymphoma, we said it's not one disease. The way we classify lymphomas is to non-Hodgkin and Hodgkin. That's the first distinction you have to make, and then the non-Hodgkin lymphomas are further divided to B cells, T cells, and primary cutaneous that can be B and T as well. B-cell lymphomas, the second distinction you have to make, it's indolent, low-grade lymphomas versus aggressive. Indolent lymphomas, you have chronic lymphocytic leukemia or small lymphocytic lymphoma, which is the lymphomatous equivalent of the same disease. You have follicular lymphoma, which is the most common indolent lymphoma, B-cell lymphoma. Marginal zone, that can be extranodal. We know about gastric mold. You guys are well aware of that, I'm sure. But it can also be nodal. It can be splenic. You have lymphoplasmacytic lymphoma, which is the lymphomatous equivalent of Waldenstrom's. That might be more well known to you. Hairy cell leukemia. These are the more common. Obviously, there are a couple more entities that are beyond the scope of this talk. Mantle cell lymphoma, it's an interesting disease because it looks indolent, it looks mature, like a mature B-cell lymphoma with no high-grade features morphologically, but it has a very high, very aggressive clinical course for the most part. So it's actually falling in between. For clinical purposes, though, you should think about it as an aggressive lymphoma. However, it can, before you get the diagnosis, it might confuse you if one takes a look at the smear, looking at those cells, it might confuse you for an indolent lymphoma. The aggressive lymphomas are the diffuse large B-cell lymphoma, the most common one. Aggressive B-cell lymphomas, high-grade B-cell lymphomas can be double hit and triple hit. We'll talk about that. High-grade B-cell lymphoma, not otherwise specified. And then less frequent subtypes such as primary mediastinal, Burkitt's, plasmablastic, and all the age-related lymphomas that are not a separate category, but all those histologies can be seen in HIV as well, but they're considered different disease. T-cell lymphomas, the most common is the peripheral T-cell lymphoma, not otherwise specified, but then you have also anaplastic large cell lymphoma, which can be ALK positive or negative, has prognostic implications. Angioimmunoblastic T-cell lymphoma, hardly ever you're going to see one case, but it can happen. It has poor prognosis. It can present with hypergamma-globulanemia. It can have a tricky and interesting presentation. One disease that it's in general very uncommon, and in other places people don't even get to see it, but you guys might encounter it more often here, is adult T-cell leukemia lymphoma. This is in patients from the Caribbean, and less common subtypes of T-cell lymphoma that we're not going to talk about. Hodgkin's lymphoma is it needs to be categorized either to classical Hodgkin's, which is what you usually see and think of, and these are the med school subtypes of nodular sclerosis and lymphocyte-rich, mixed cellularity, lymphocyte Hodgkin, versus the non-classical, which looks morphologically similar, but it has a different protein expression of the cells, and it's for the nodular lymphocyte predominant Hodgkin's is a little bit more indolent disease, and it expresses B-cell markers that classical Hodgkin's does not. A little bit of epidemiology. It's lymphomas are fairly common, but obviously not as common as other malignancies such as breast or colon. That it's in the multiple hundreds of thousands per year in the US only. Um, it's a little bit more common in men, both non-Hodgkin's and Hodgkin's lymphomas. Non-Hodgkin's lymphomas are more frequent in older individuals. Hodgkin's lymphoma has this bimodal age distribution, so you see them in the adolescent young adults, and then you see them again in older individuals. Risk factors. There is a lot of discussion about genetic predisposition of lymphoproliferative disorders. The strongest association has been seen in chronic lymphocytic leukemia, less so in DLBCL, follicular, or Hodgkin's. There is a clear association with autoimmunity that might be a factor of the chronic antigenic stimulation, immune stimulation, plus minus the immunosuppressive treatments that those guys frequently undergo. Immune deficiency is a well-known risk factor. We have the age-related lymphomas to prove that, and we have the post-transplant lymphoproliferative disorders, also in the setting of immunosuppression. And in association with specific infections, HIV is the complex relation is likely more driven by the immunosuppression of the viral infection itself. EBV, Epstein-Barr, has been associated with quite a few subtypes of aggressive lymphomas, Burkitt's, Hodgkin's, plasmaplastic, and some types of DLBCL. It's good to know that there is a strong association with hepatitis C chronic infection and marginal zone lymphoma, particularly splenic marginal zone lymphoma. But as you're going to see later on in one of the cases, any actually chronic infection can be in a way associated with marginal zone lymphoma and lymphoproliferative disorder in general. HSV-8, the Kaposi virus, is associated with primary fusion lymphoma. You're hardly ever going to see that subtype of lymphoma. It's more commonly seen in HIV, but also can be seen in non-HIV patients. But this is an association that you should consider. Presents with effusions, and you find HSV-8 positivity. You all know the association of H. pylori and gastric malt, and you should also know the association of HTLV1 and ATLL, adult T-cell leukemia lymphoma. We're talking about a little bit of pathogenesis. It's good to know that the normal route first, and then see how carcinogenesis develops. A B-cell maturation and differentiation is a very complex process that involves immunoglobulin G rearrangement and somatic hypermutation, recombination. These are all genetic events that happen in the normal maturation trajectory of the B cell. However, in all of those phases, the B cells are at risk of genetic events that skew their differentiation carcinogenesis. And we'll see, depending on the heat, we develop a different type of lymphoma. All right, so the normal life of the B cell, you start from the bone marrow milieu, you have the stem cell that give rise to the progenital B cells. Those cells start to rearrange the heavy chain genes and then the light chain genes in order to develop this B cell receptor in the surface of the lymphocyte, which eventually is going to make the lymphocyte bone marrow, the bone marrow, and circulating the periphery and entering lymph organs such as the spleen and the lymph node. And there, the fate of the B cell can be variable. It will encounter an antigen, and either is going to generate a short-lived plasma cell, or it's going to go what we call the germinal center reaction, where those B cells now try to become more efficient B cells to produce the more efficient immunoglobulin. So they undergo somatic hypermutation, multiple mutations within the immunoglobulin genes, in order to produce the immunoglobulin that fits more the antigen of interest. And then once that happens, they undergo a class switch, the change in their immunoglobulin from IgM to IgG to Ig and so on, and then they progress past the germinal center reaction to a plasmablast and eventually a memory B cell or a plasma cell that will be able to produce the right antibody to fight the infection or wherever the antigenic stimulation was coming from. So in this process, given the multiple genetic alterations that the B cell is undergoing, there is a possibility that some abnormal events will take place that will lead to carcinogenesis. And as we said, depending on what stage, what phase of that B cell maturation differentiation process that happens, you can get different neoplasms. So if it happens early on, the bone marrow, the progenitor cell, you're getting ALL, acute lymphoblastic leukemia, immature cells. If it happens later on in the mature B cell state, before the germinal center reaction, you can get mantle cell lymphoma, or you can get a subtype of CLL, SLL, with unmutated immunoglobulin genes. Within the germinal center, you can get the aggressive or non-aggressive lymphomas. You can get a DLBCL, Burkitt's lymphoma. These are all potentially germinal center positive lymphomas, follicular lymphoma as well. And post the germinal center reaction, you can still get a DLBCL. We call them non-germinal center DLBCLs. You can get plasmablastic lymphoma. You can get we didn't speak about within the germinal center reaction. You can also get CLL, which is the mutated immunoglobulin gene chain, immunoglobulin heavy chain CLL, which is a more prognostically favorable disease. And ultimately, you can get in the plasma cell stage, you can get multiple myeloma, which is not a lymphoma. It's a different disease, but it's a B cell, mature B cell disorder. All right, going to the diagnosis, we touched upon that. It's very important to know that fine needle aspiration is inadequate to make a diagnosis, particularly even more so for Hodgkin's lymphoma. Sometimes with aspiration, you can get a flow cytometer that gives you the immunophenotype of those abnormal cells, and you can get a hint. Hodgkin's lymphomas, as we're going to see, is a disease that the neoplastic cells are the minority of the cells within the swollen lymph node, and almost universally the flow cytometry is a useless test. So you need the architectural information that can give you the final diagnosis. So we do want an excisional biopsy, and we should always fight for that if possible. Reserving the core biopsy, a CT-guided, for example, procedure for those cases that we feel that an excisional biopsy cannot be done. And you should always keep that at the back of your heads, because you're going to get some push back from the services that you're asking to do the procedure. But you know, there've been multiple occasions where an FNA led to a week or 10 days of delay in the diagnosis, during which time the patient developed, you know, let's say significant LFT abnormalities, losing a major organ that compromises the chance to tolerate the right chemotherapy, developing immune complications and hemolytic anemias that prompt steroid introduction, and then you mess up your ability to actually diagnose them right. So it's a complex process. Even if the patient looks stable, we should always try to get that excisional biopsy done. CLL is maybe one of these diseases that you don't really have to undergo a biopsy to diagnose. You usually have this burden of disease circulating in the bloodstream, and you can easily characterize those cells by ordering a flow cytometry that gives you the immunophenotype, and you can get the diagnosis by just that. All right, talking about the workup now. for the most part, you're going to have some labs, so it's not that you have to wait for the pathology to order the right workup, but you definitely need to see the hematologic profile. You want to see kidneys, you want to see liver, you want to see LDH and uric acid, and the reason for that is what? Anyone? No one? All right, LDH is a marker of proliferation of these disorders. It gives you a sense of burden of disease that you're dealing with. Uric acid is an important parameter that you have to take into account in the treatment of lymphomas because it's a marker of tumor cell lysis, and we're concerned about tumor cell lysis syndrome. You need to know if the patient is HIV positive or not. It has some therapeutic implications. It definitely can affect your management altogether. You need to check for hepatitis B and C, both to know if there is a predisposition, but also because it has therapeutic implications. Some of the chemotherapy agents and the immunotherapy agents that we use in the treatment of lymphoma can make those infections worse. So it's always important to know before you pull the trigger and treat. And some of the other labs listed here have prognostic implications. SED rate for Hodgkin's, classical Hodgkin's, beta-2 microglobulin for follicular and CLL, and HDLV. It's always a test that you want to send if you're dealing with a T-cell lymphoproliferative disorder, particularly with the right epidemiologic risk factors to make sure that you're not dealing with ATLL, which is a horrendous disease that can make a therapeutic strategy pretty quickly different than what you would do for other T-cell diseases. Staging, you need, as you understand, you need to stage the extent of the lymphoma involvement. So you need to know, is it one side only or is throughout the body? But PET-CT is actually the best imaging study for the majority of lymphoproliferative disorders and lymphomas, with the exception maybe of CLL, SLL, the lymphoplasmacytic, the marginal zone lymphomas, and mycosis fungoides, which is a T-cell indolent disease that can eventually progress to more advanced stages. And usually bone marrow biopsy is a required test to make sure that the marrow is not involved by the lymphoma. You might be able to spare the patient from a bone marrow biopsy if you have a PET-CT to stage Hodgkin's and DLBCL. None of the other histologies, you're good enough with a PET-CT alone. Echo and MAGA is more like a management issue. Part of the treatment chemotherapy includes anthracycline, so you always want to make sure that you know what's the baseline cardiac function of the patient before you expose them to a cardiotoxic treatment. So how do you stage? Let's say you get the imaging studies and you see where the lymph nodes are. Based on where they are, you assign a stage 1, 2, 3, 4. Stage 1 is one lymph node station, one side of the diaphragm. Stage 2 is multiple lymph node stations at the same side of the diaphragm. Stage 3 is lymph nodes above and below diaphragm. And stage 4 is a solid organ extranodal disease, such as liver, bone marrow, any extranodal disease. Extranodal means not lymph node tissue. Any solid organ involvement will qualify for stage 4 disease unless it's a lymph node mass adjacent to the solid organ eroding into that organ. We'll talk about one of our cases as an example of that. Spleen is considered a lymph node organ, so it wouldn't make you stage. It wouldn't upstage you. It would upstage you if you had chest lymphadenopathy and you had a spleen, which is another lymph station in a way below the diaphragm. But if you had abdominal lymphadenopathy and spleen, you wouldn't go from 2 to 3 or 3 to 4. Right. Let's talk about the most common histologies. DLBCL is the most common aggressive B-cell lymphoma. about 30 or 40% of all non-Hodgkin's lymphomas. Pathologically, you see this diffuse effacement of the lymph node with large neoplastic B cells. They look large and irregular. And going back to that, trajectory of the B cell maturation, the hit can happen within the germinal center reaction or post germinal center, and you have these two different cell of origin diseases. The germinal center subtype, which usually is the good prognosis one, and the non-germinal center, which has a much worse prognosis. This is what the pathologist is going to go through to determine cell of origin based on immunohistochemistry. It's too much for you. I don't think that you should necessarily remember any of that, but that's what we do. You try to prognosticate the LBCL by using several clinical parameters that, as you see, and then you create a score, and you see what the chances that your patient is going to do better or worse. So we use the IPI score and the revised IPI score. Age more than 60, advanced age, more than one extranodal site, um, elevated LDH, and performance status are the parameters that we care for. And that revised IPI or IPI score has really maintained its value across the board in modern era of therapeutics as well. So it's an important prognostic parameter. You can see here that if you have a very good score, the chances that you're going to survive are in the 90% range, and it goes down as your score increases. And if you have a high score, for example, you are about 50% to survive at 4 and 5 years. And you can see the graph here, the Kaplan-Meier curves that show the nice separation based on the score. High-grade B-cell lymphoma, it's a new entity under the WHO classification. These lymphomas usually fall under the umbrella of DLBCL, the diffuse large B-cell lymphoma, but there's some characteristics that make them a little bit different. That's why they're classified in a different manner. The proliferation index is higher. The morphology might be not the typical large cells. You might have a medium to intermediate to medium to large size. You can have some Burkitt-like features like the sky pattern in the morphology, and so they tend to behave a little bit more aggressively. They used to be called DLBCL / Burkitt's-like lymphomas. Now, when you see those features, you always want to make sure that you send further genetic analysis. You want to send FISH to look for rearrangements of the c-MYC, the BCL2 and BCL6 genes. That if you find any rearrangements on, then you are classified as double, triple hit lymphomas, which are the extremely worst bad prognosis lymphomas that we currently seeking novel treatments to improve outcomes on. So yeah, those diseases tend to present at advanced stages. Hardly ever you're going to see an early stage double, triple hit lymphoma. Frequently have bone marrow involvement, CNS involvement, and if they don't have CNS involvement, they are definitely at high risk of CNS involvement down the road. They need to be prophylaxed more aggressively. You're going to see high LDHs and high IPI scores. And the same applies in a way in those high-grade B-cell lymphomas, even in the absence of those gene rearrangements. However, the prognosis tends to be a little bit better. However, you need to treat them aggressively and prophylax them for CNS, for example, aggressively as well. And I mean, the treatment of these diseases, it's an ongoing struggle. The paradigm of treatment in general for aggressive lymphoma and the DLBCL in specific is chemotherapy. I guess for the purposes of a resident, knowing that we use for the most part R-CHOP is good enough. It still stands after all those years as the mainstay of chemotherapy for the big bulk of DLBCL. There might be a couple of occasions that one would use a more aggressive backbone, such as dose-adjusted EPOC, That's reserved for age-related lymphomas, primary mediastinal, and double, triple hit lymphomas, as we said before. You reassess response by PET-CT after 2-3 cycles. If you see a favorable response, you continue with the same chemo. Depending on the stage, you're going to do 4. For earlier stage, you're going to do 6 cycles. For advanced stage, and at the end of your treatment, you're going to restage with another PET and see now I'm done. Is it complete remission or not? And if you complete remission, for the most part, you're going to put them on surveillance, and you're going to keep an eye on them in the clinic and maybe some subsequent imaging as needed. If you don't see full remission, you might consider radiation. If you think that the disease is really refractory, hasn't really remitted that well, then you're gonna move to a salvage regimen and take someone to an autologous transplant. The same thing that you would do for someone that remits well, but a few months after, a few years after relapses, you're gonna utilize salvage chemotherapy and try to take them to an autologous transplant if they're chemo sensitive. And thank God nowadays we have some treatment options for a chemo-resistant disease. So those diseases that no matter what chemotherapy you give them, they don't really move. You can employ immunotherapy such as CAR T cell therapy in case they're able to get there. Age-related lymphomas, again, it's a big category of lymphomas. For the most part, the histology is DLBCL, but you can have more frequent histologies as well: Burkitt's, plasmablastic, primary fusion lymphoma. As we said, it's more common in HIV than not. Plenty of evidence supporting the dose-adjusted EPOC as the main regimen chemotherapy-wise for age-related lymphomas rather than R-CHOP. You have to be careful where to dose the rituximab. Rituximab is anti-CD20 immunotherapy agent, antibody. CD20 is a B-cell marker in the majority of those B-cell lymphomas. So when you have positivity for CD20, you can use Rituxan or any other B-cell targeting agent, but you don't want to use it for someone that is severely immunocompromised, HIV-wise, with a CD4 count of less than 50. So you have no T-cell immunity. You don't want to kill the B-cell immunity either. So likely that's the case where you're going to hold off on the Rituxan until later, try to treat the HIV and the lymphoma and integrate it later. High risk of CNS involvement. So for some reason, above and beyond the histology on its own, so CNS prophylaxis is integrated as part of the management of HIV-related lymphomas. And opportunistic infection prophylaxis is integral throughout the course of chemotherapy, even if they don't really meet criteria, a diagnosis in terms of CD4 counts. So you will bacterium prophylax them throughout the course, even if there are more than 200 of diagnosis. Burkitt's lymphoma, it's, thank God, not that common of a disease, although it has high cure rates. It's maybe the most aggressive B-cell lymphoma known. It has medium-sized cells. The typical question in boards might be starry sky pattern in the pathology specimen. These are macrophages that have phagocytosed adjacent cells, and they give this appearance. So you see that, you go with Burkitt's as the answer. We have 3 clinical variants. The endemic that you might have read about in during your medical school years in Africa is EBV associated. It's localized in the jaw more than other sites. The one that we usually see here is the sporadic form that has a predilection for a GI tract, and you can actually see a lot of nodal disease, the typical lymph node swelling, more in adults than in children. And you can definitely see Burkitt's in immunosuppressive states such as HIV. It's not pathognomonic, but it's very suggestive if you see a c-MYC rearrangement, a translocation 8-14, the c-MYC being on the chromosome 8. rearranges with the immunoglobulin heavy chain on chromosome 14 or 22 of the lambda light chain. And this is a driver, genetic alteration, pathogenetic alteration. The Ki67 is a proliferation index, and Burkitt's is near 100%. It's again the most proliferative disorder you can see. And what does that mean for you? It means that if you have someone that you're suspecting Burkitt's, or you know that they're Burkitt's, their disease can change in front of your eyes. You can, the patients can decompensate at any given time. The disease can double within a couple of days. So absence of symptoms on Monday doesn't mean that on Wednesday you're not going to have something new. So you need to sit on top and act fast in a disease like that. Extremely high risk for CNS disease. Obviously, depending on the stage of the Burkitt's lymphoma itself, the higher the stage, the higher the risk. But CNS prophylaxis is always integrated in treatment schemas of Burkitt's. High risk for TLS, particularly with high burden of disease. But if you had to choose one lymphoma subtype that you would be aggressive in TLS prophylaxis and management, that would be Burkitt's. Chemotherapy, usually it's more aggressive combinations of chemotherapy, so it's a hypercivet. Dose adjusted EPOC being a pretty solid choice nowadays, with accumulating data showing that. And the good news, although rocky road, is that in the vast majority of cases you have cures. It is this subtype of Burkitt's that if it doesn't respond to the first line of treatment, it's really hard to treat and salvage, as opposed to other lymphomas. But thank God that's not frequently the case. But talking about Burkitt's and aggressive lymphomas, I think that for you guys, medical residents, you should always think about tumor lysis syndrome in those lymphomas. And there are a couple of parameters that you have to consider to assess the risk. Yes, all those guys are going to be followed by oncology. They're going to tell you what to do, but you should be aware of that the Burkitt's lymphoma, the double, triple hits lymphomas, high-grade lymphomas, and DLBCLs with descending order, put the patients at increased risk. And then beyond the histology, you take into account the bulk of the disease. So it's different. You have a DLBCL with a lymph node mass of 3-4 centimeters, different if it's 11 centimeters. The LDH will upstage you. Let's say that you say it's mild risk, but you have high LDH. Then you're going to say, all right, the combination of the two will make me moderate risk. And the same applies with renal function. So if you have already CKD, that will put an additional risk factor in your evaluation of the TLS risk. But always consider that when you're taking care of a lymphoma patient on your ward till transplantation, until the diagnosis is put. Make sure that you keep an eye on those parameters. Even off treatment, very aggressive lymphoproliferative disorders can go to spontaneous TLS. So you always trend those labs. You always make sure that you put some hydration on them, keep an eye on the ins and outs and so on. And equally, you should be very vigilant about neurologic symptoms that might develop on those guys. A Burkitt's patient, for example, with intact neurosystem on Monday might start, complaining about something a couple of days after. You should always think of CNS involvement in these lymphomas, and definitely Burkitt's is the top of your list in terms of risk. Double, triple hits come afterwards and very close. High-grade lymphomas and HIV-related lymphomas and so on. For your typical DLBCL, not all DLBCLs go to CNS. The risk is much less compared to Burkitt's lymphoma. And so there is a prognosis score that people have developed to get a sense of the patient in front of me, what are the chances. And that will guide your management. Am I going to CNS prophylax someone, or is that too excessive and possibly toxic for the patient? So some disease localizations have been traditionally associated. Involvement of the breast, the testes, adrenals, and kidneys um, have been most associated, but also bone or bone marrow involvement, and location of disease in the spine, around the spine, or in the sinuses. We have the CNS IPI score, which is essentially the IPI score, the risk prognostic score for DLBCL in general, plus adrenal and renal involvement, to assign a risk and decide on the management of CNS prophylaxis. That might be redundant for you, but this is what the heme pathologist is going to go through to assign a diagnosis based on immunophenotype. These are the results of flow cytometry, primarily for the indolent lymphomas, but it's too much for you. All right, and moving on to the indolent lymphomas, the first distinction that you have to make is it early stage or advanced stage? Indolent lymphomas take time to grow and or become symptomatic or require treatment, but once they are advanced stage, are not considered curable for the most part. There might be a possibility that you can cure some of those guys if you catch them early in the stage at the stage 1 or 2 phase. So if you have this localized follicular lymphoma, for example, you might still hope for cure. And the treatment is based on maybe not ideal quality data. However, the standard of care is considered for the most part radiation, depending obviously on the site and whether that can be safely radiated. But if it can, radiation is the treatment of choice. Uh, Plus minus immunotherapy such as Rituxan, single agent rituximab as opposed to combination with chemotherapy might be good enough for an indolent, low bulk, early stage lymphoma. And some people would still do walk and wait. Um, and controversial, but for the right patient, it might be the right choice. And as I said, advanced stage is considered incurable, but the good news is that not everybody requires a treatment. They can live long lives without treatment, even with the presence of lymphoma in them. So the distinction that one has to make when they are diagnosed with advanced stage indolent lymphoma is, do I need to treat or not? Do I watch and wait or jump into treatment? And there's some indications for that. Follicular lymphoma being the most common indolent B-cell lymphoma, uh, essentially guides the management of most of indolent lymphoma. So the data are really originated from follicular lymphoma, extrapolated into other indolent lymphomas. Follicular lymphoma has three different subtypes, depending on how many centroblasts or centrocytes. This is a germinal center reaction cells. The centroblasts are those that undergo somatic hypermutation. They're large cells that look very atypical. You have a lot of those cells. You're more immature, like follicular lymphoma, higher grade lymphoma, and you're assigned a risk of 3A or 3B. If you have more centrocytes, you're low grade 1 or grade 2. Grade 1, grade 2, and likely 3A are considered the typical indolent follicular lymphoma. Follicular lymphoma 3B is considered the equivalent of DLBCL and is treated as such. But for non-3B follicular lymphoma, you have to undergo the thinking process that I just mentioned. Do I need to treat? What's the stage? If it advanced, do I need to treat now or wait? And the Guelph criteria were developed in order to help the clinician make that right decision. So if you have bulky disease of a lymph node mass more than 7 or multiple more than 3, if you are in a leukemic phase, or if you have cytopenias, if you are symptomatic, have these symptoms and other symptoms, if you have symptomatic splenomegaly, if you have effusions, it's pretty much obvious that the treatment cannot wait and you need to treat. But in the absence of those, let's say that you have lymphoma, but you have 2 centimeter stage 4 lymphoma, but stage 3 lymphoma all over the place, but low bulk, asymptomatic, good blood counts, normal organ function, then these are the guys that you can actually watch and watch for years before you intervene. And there are also prognosis scores for follicular lymphoma try to assess the risk of progression-free survival in this disease, taking into account bone marrow involvement and cytopenias and age and bulk and bone marrow involvement and so on. When it comes to treatment, when you really have to treat advanced stage follicular lymphoma, there are a couple of choices. I don't think this is what necessarily is the scope of this talk. I don't think you're going to get into treatment details. I'm not sure what the in-service exams is asking for you guys when it comes to lymphoma, but bendamustine rituximab is likely the standard of care for most patients if they can tolerate. You might have a case of low bulk advanced stage follicular lymphoma that you want to treat, and these are the cases that you might treat with single agent rituximab, the least toxic intervention. And then there is the concept of maintenance that has a progression-free survival benefit, not overall survival benefit. It's a matter of discussion with the clinician and the patient. Moving on to CLL, which might come as the next more common indolent lymphoproliferative disorder. Before we talk about CLL, there is this entity that we call monoclonal B cell B lymphocytosis, which essentially is monoclonal looking B cells, but the burden of disease is not enough to call someone yet CLL or SLL. So you have peripheral blood monoclonal B cells that are less than 5,000, and you don't really have extranodal disease, which would qualify for SLL, for the lymphomatous component. The immunophenotype is usually the CLL immunophenotype, although sometimes those lymphocytes can have a marginal zone lymphoma immunophenotype. You should think of it as you think of MGUS in myeloma. So it's like a precursor stage of disease that has an annual risk of about 1% of transforming or progressing to CLL. And you can try to risk stratify that risk by assessing the amount of monoclonal B cells. So if you have a tiny amount, less than 0.5, the chances are that you're going to be good, the same that you would do for a low risk MGUS. Don't need to have an oncologist. The primary care can follow. But if you have greater than that, greater than circulating monoclonal B cells, then you need a little bit more close follow-up with an oncologist, make sure that it stays like that and it doesn't progress to a more advanced stage of disease. So CLL now, by definition, is more than 5,000 of those monoclonal B cells. And SLL is less than that, but extranodal disease, extramedullary rather, so nodal disease, lymph node swelling. The way we stage SLL, it might be well known to you. We use the RISE system. Dr. Rai is still alive and active in LIJ. He's a big expert in CLL, and has given us the staging system that we still use to determine when to intervene and when to treat. So if you have just lymphocytosis in the absence of any lymphadenopathy, you're stage 0. If you have lymph nodes in addition, then you're stage 1. If you have spleen involvement or liver involvement, you're stage 2. And if you start developing cytopenias, anemia, you're stage 3, thrombocytopenia, stage 4, with the caveat that you need to make sure that the cytopenia is really due to burden of disease in the marrow and it's not an immune phenomenon. You're entitled in all lymphoproliferative disorders, but particularly so in CLL, to develop autoimmune hemolytic anemia or thrombocytopenia that you can manage as you would do in a non-CLL driven setting, and escalate the treatment if you have resistant or refractory disease. But for staging purposes, you need to make sure that this is not an immune-mediated cytopenia. And so the indications to treat CLL might be the prototype of this watch and wait management strategy, where you not necessarily need to treat a patient that has leukocytosis for years and years. So when we talk about CLL, so circulating lymphocytes, if you are if you have less than stage 3, you usually do not treat unless you're becoming symptomatic for one reason or the other. So the spleen is enlarging, or the splenomegaly is symptomatic, or you develop these symptoms and so on. Usually, you reserve treatment for CLL when you develop cytopenias that are not immune mediated, so anemia and thrombocytopenia. When you don't really have CLL, but you have the SLL, you go by what you would usually do for an indolent lymphoma, right? So if you're symptomatic, you're losing weight, you're fatigued, you have these symptoms, you're at risk for end organ damage, or you have bulky lymphadenopathy, which might be the most common situation to treat a disease like that, then you do treat. And as I said, immune cytopenias are not an indication to treat with CLL SLL directed treatment unless they're refractory to the first line therapies, in which case you're going to employ more CLL specific treatment. When it comes to selecting the treatment, it really depends on risk stratifying the disease. Too much information for you. However, in general, you need to know that we care about cytogenetics, p53 deleted or mutated disease, deletion 11q. These are bad things. We care about immunoglobulin heavy chain mutational status. Again, talking about the maturation trajectory of the B cells. The hit can happen before the somatic hypermutation, and this is a high-risk disease. It can happen after the somatic hypermutation, and it's a better disease to have. And we use CD38 and ZAP70 sometimes as a surrogate market for this mutational status. And complex karyotype is usually bad in any disease, but when you have multiple genetic alterations, that's not good. You decide on the treatment based on genetics and based on the fitness of the patient. But if you have to know something nowadays, is that novel treatments such as BTK inhibitors with ibrutinib being prototype with that is that it has become the standard of care for the majority of patients. Chemotherapy such as FCR, fludarabine, fludarabine, cyclophosphamide, and rituximab is reserved for maybe a subgroup of young patients, fit patients with mutated heavy chain immunoglobulin gene, in which case chemotherapy has shown maybe a signal for cure even with progression-free survival exceeding 10 years. So it might have some place still, but for the most part, we're kind of steering away from chemotherapy in the treatment of CLL, SLL, and we utilize those novel approaches. Venetoclax is another big agent in the treatment of CLL. It's a BCL2 inhibitor. BCL2 pathways highly activating CLL. Those cells are extremely sensitive. It has also changed the treatment paradigm in CLL, and it's moving to the front line more and more. So yeah, too much information for you, but as a general idea. And a couple of other pearls when it comes to indolent lymphomas. Again, know the association of H. pylori and malt lymphoma, gastric lymphoma. And if you have an early stage 1, for example, a gastric malt H. pylori related, the standard of care is treatment of the H. pylori infection rather than a lymphoma-like treatment. You need to know the association of hepatitis C infection, chronic hepatitis C, and a splenic marginal zone lymphoma. And lastly, a little bit on the mantle cell lymphoma, which we said looks mature, indolent, but is aggressive. And that's the case for the vast majority of cases, except some subtypes of disease that have non-nodal disease in the beginning, and it can have a more indolent course. However, they can transform to a more aggressive disease. the genetic hallmark lesion is the translocation 1114, is cyclin D attached to the immunoglobulin heavy chain gene, makes the disease more proliferative. And we always test for that to differentiate mantle from CLL, which has otherwise a similar immunophenotype. But GI involvement is frequently seen, so you can have colonic or small bowel involvement. And the treatment is aggressive chemotherapy plus minus autologous transplant in first remission as a prioritization upfront for the right patients. A few words on classical Hodgkin's lymphoma. Important to know that, as we alluded to in the beginning, that the Hodgkin cells, those Reed-Sternberg cells, are the minority in the pathology specimen that the pathologist is going to assess, and that has been frequently the reason why the diagnosis can be delayed. Sometimes, even if you have an excisional biopsy, you might be having hard time locating those neoplastic cells, and you just see the background inflammatory reactive changes consisted of lymphocytes and steatocytes and neutrophils and eosinophils and plasma cells. So yeah, when you see that pattern, you suspect lymphoma, you always have to raise the suspicion of Hodgkin's lymphomas to help even the hematopathologist think towards the right direction. And the usual, maybe a couple of things that you have to assess in a Hodgkin's patient, even more so than any other lymphoma. B symptoms, for example, are not included in prognostications of other lymphomas that much, but they play a huge role in Hodgkin's. So B symptoms you should always assess in Hodgkin's. B symptoms being a fever more than 38 Celsius, drenching night sweats, and unexplained weight loss of more than 10% of the body weight within 6 months. We did say that pruritus is it's a very common symptom, call it paraneoplastic, of Hodgkin's. There are stories of people that had pruritus for months or years before they got diagnosed with a lymphoma. And it correlates very well for the not every patient has it, obviously, but if you have it, it's a good marker of disease. It can precede or correlate really nicely with what's happening systemically, Hodgkin's wise. And another infrequent that I've never encountered, but it's well documented in literature, is alcohol intolerance. Some people drink alcohol and develop significant pain at the sites of disease involvement. So yeah, talking about our first case, for example, pruritus is a hint towards the right diagnosis. You try to risk stratify by bulk, sedimentation rate, and B symptoms, and then you also use the International Prognosis Score to get a sense of how the patient is going to do in the long run. Obviously, I don't expect you to memorize any of that, but you also have to go back and check what if the patient is meeting any of those IPS parameters and assign a risk. So only zero parameter, like more than 90% cure rate, dropping about 10% for each additional risk factor. All right. And how you treat, again, it matters what stage you are, as in every lymphoma, but even more so in Hodgkin's. You try to de-intensify chemotherapy and spare patients from chemotherapy and radiation if you have early stage disease and no additional risk factors. So you assign risk of the stage, and then you assign favorable and unfavorable characteristics to determine how you're going to manage those patients. And again, unfavorable characteristics are B symptoms, elevated sedimentation rate, and the extent of nodal involvement, 2 or 3 or more sites. And the treatment is chemotherapy plus minus radiation. Radiation is very efficacious in Hodgkin's, has been used for years and years. Trials that try to compare chemotherapy to chemotherapy plus radiation have always favored radiation. However, the problem is that this is a highly curable disease, and the radiation has long-term toxicity that has become a major issue for those patients that often are young at diagnosis, as we said, by model age distribution, adolescent young adults. You can radiate someone at their 20s and they can have um, breast cancer when they're 40, MDS, AML, early cardiovascular disease. So, we try to use radiation as less as possible in otherwise curable, highly curable disease. ABVD, if you have to learn another acronym for chemotherapy, has been the standard of care for years in the treatment of Hodgkin's. That paradigm has changed recently with incorporation of more targeting agents such as brintaximab, which conjugate antibody with chemotherapy targeting CD30. CD30 is a Hodgkin's, it's a marker that's seen in Hodgkin's lymphoma. CD15 and CD30 is the positive markers in the immunophenotype of classical Hodgkin's. And so we have an agent targeting those CD30 cells, and it was superior to ABVD. So that is becoming the new standard of care. All right, so with that presentation, let's go through the cases as well and see if we can get a better idea. The first guy was a young guy with B symptoms and lymphadenopathy. He had pruritus. Somebody said, I'm suspecting Hodgkin's more than non-Hodgkin's because of the pruritus. And that's right. He was diagnosed with nodular sclerosis, classical Hodgkin's. Staging showed lymphadenopathy, supraclavicular, axillary, and lung nodules in PET-CT, FDG AVID. What is his stage? Anyone?
Or extranodal.
Exactly, yeah. If you had a mediastinal mass and running into the lung parenchyma, would that change anything?
Well, if it's not, yeah, it's different because it's nodal.
It's different because it's what?
If it's at the lymph node, it will be nodal disease, so it wouldn't be.
Right. Yeah, it would be a bulky, potentially stage. Let's say that we only have chest and neck. It would be a stage 2E with extranodal disease, but not 4. But if you have mediastinal mass and a peripheral lung nodule, then you'll be 4, as was the case in his guy. And how do you want to stage this guy? Now we go to PET-CT. Do we need a bone marrow? Huh?
No.
So we said that Hodgkin's is one of these histologies where PET is extremely sensitive, and it's hardly ever the case that you're going to have early stage in PET-CT and the bone marrow is going to be positive. So per Lugano classification and recommendations, you can actually spare that patient from a bone marrow. If for whatever reason this guy could not get a PET-CT and you were staging him with the CTs only, then a bone marrow biopsy would be required. All right, so yeah, so he had the lymphadenopathy, we said, and so on and so forth. And looking at the labs, he had lymphopenia. He's a young guy. He's a male. He has elevated ESR. He has less than 4 albumin. He has a couple of risk factors by IPS, so he would fall into a moderate risk disease. And this guy actually responded nicely, responded suboptimally actually to the initial part with ABVD chemotherapy. He was escalated with BCOP regimen. He achieved remission, lasted for 4 or 5 months, and then he relapsed. He underwent autologous transplant, maintenance therapy. At the end of maintenance, he relapsed again. So bad biology. So the IPS score, the extranodal disease, gives you a sense of who's not going to do that well. Second guy, we all thought it was an aggressive lymphoma. If we go by statistics, the chances are that we're dealing with a DLBCL. B cells are much more common than T cells, right? and within B cells, DLBCL is the more common aggressive histology. He indeed have DLBCL looking cells in the initial pathology. Then we sent, but high Ki67 proliferation index. So we did send for FISH, and he had c-MYC and BCL6 rearrangement, which we said makes him a double hit lymphoma. He's currently under treatment with great response. All the swelling and the edema melted away after one cycle of chemotherapy. Was all obstructed because of the lymph nodes. But if I was asking you, this guy with this lab, with that histology, the proliferation index, before you give him the first cycle of chemotherapy, what would be your concerns? What you would be more concerned about?
Tumor lysis syndrome.
Tumor lysis syndrome, exactly. High grade of disease, a little bit of elevated LDH, not sky high, but elevated, but huge burden of disease. I didn't tell you that, but the CAT scan had shown multiple bulky nodal masses, the largest being the peripancreatic one, up to 11 centimeters, but other ones 8 centimeters, and other ones at 6 centimeters, so on. So big bulk of disease, very aggressive disease, high risk of TLS. We chose to treat this guy as an inpatient as opposed to keep him at the outpatient setting. Third case, it was pretty obvious to all of you that we were talking about a CLL case. This is an elderly guy. CLL is a disease affecting more the elderly. He had a pretty unremarkable hematologic profile except for the lymphocytosis. He didn't have any lymphadenopathy on exam or in imaging. So he's a stage 0 CLL. What do you do for a guy like that, or a patient like that?
Close follow-up.
Do you treat? Do you wait?
Wait.
Repeat the labs every year.
Yeah, but annual follow-up was more for the monoclonal lymphocytosis. CLL, you keep an eye a little bit closer eye. One of the indications to treat that I didn't mention, I missed to mention, is the doubling time. Doubling time defined as doubling of the WBC or the lymphocytosis within 6 months. So definitely you want to keep an eye every 6 months to make sure that the disease is moving towards the right direction. And usually high doubling time is followed by cytopenias sooner than later. So yeah, this guy, watch and wait. It might take years before he requires, if at all, treatment. And the fourth case, it's a very interesting that I use this case so that you understand that to contrast that with the CLL guy. So you have a mature-looking lymphocytosis on smear, for example. The cells look really mature. They don't raise a suspicion of or immature process, such as a leukemic process or even an aggressive lymphoma, DLBCL, for example, in leukemic phase would have large-looking cells. So mature lymphocytosis, but cytopenias and extremely high LDH that raises suspicion for more aggressive than not histology and liver involvement. Imaging in these guys showed really splenomegaly and some prominence of the liver. He underwent flow cytometry of his peripheral blood and a liver biopsy that showed involvement by the lymphoproliferative disorder. Those cells were CD5 negative, CD10 negative, which we didn't talk much about, but this is what we do to say, is that CLL? It's not. So this is a marginal zone lymphoma immunophenotype consistent with marginal zone lymphoma with a big spleen. It looked more like a splenic marginal zone lymphoma. Regardless, it was call it as you want, a marginal zone lymphoma. He would, because of the presentation, the aggressive presentation, he was treated with modified chemotherapy based on his liver function. Whenever we're able to to dose at the time with improvement, and then he was actually kept on single agent rituximab with resolution of splenomegaly and all his cytopenias. This guy was chronic hepatitis B patient, so the hepatitis B activity correlated pretty well with his lymphoma activity. It recurred off treatment for some reason due to non-compliance. Hepatitis B viral load exploded years after, and his marginal zone lymphoma recurred at the same time, again in leukemic phase, again put back in remission with single agent anti-CD20 regimen. So it's an interesting case because it has this very aggressive presentation. Everybody was thinking of dealing with an aggressive lymphoma. Even when the immunophenotype came back as an indolent lymphoma, we were thinking that maybe we still are with transforming disease somewhere else that we're unable to cut in biopsy. However, his clinical course is a proof to the fact that we were actually dealing with an indolent lymphoma, and aggressive lymphoma would not be managed easily with single agent rituximab. So it's not everyone is reading the book all the time, but speaks for the fact that lymphocytosis is not the only parameter. You look at the big picture. You look at the cytopenias. This guy, if he was CLL, he would be stage 4. He would still require treatment. Indolent lymphomas can present with leukemic phases as well. So if something doesn't smell good, it's you need to dig deeper. I had another case that looked like CLL but ended up being follicular lymphoma in leukemic phase, and he had these more high risk features that required treatment. Okay, this is pretty much it for